Hello, thank you for taking the time to learn more about the use of seclusion and restraint. At the end of this education, participants should be able to define seclusion and restraint, identify appropriate versus inappropriate uses of seclusion and restraint, summarize the Eastern State Hospital seclusion and restraint policy, describe requirements for seclusion and restraint orders, understand how to apply and monitor someone in seclusion or restraints, recognize when to discontinue and how to document when someone was placed in seclusion or restraint, identify alternatives to seclusion and restraint, recognize adverse outcomes associated with the use of seclusion or restraint, and gain a better understanding from the patient's perspective on the use of seclusion or restraint. First, it is important to understand what constitutes a seclusion or restraint. Seclusion is the confinement of an individual in an area that restricts or forbids free movement. This typically takes place in a seclusion room, but seclusion could also be if a staff member stood in front of a patient's bedroom door, not allowing them to leave. Any restriction to an area that forbids them from leaving is considered a seclusion. Restraint is any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, body, or head freely. There are two types of restraint. First, physical restraint involves staff holding an individual, and then mechanical restraint is the use of mittens, garments, or a mechanical device that immobilizes or reduces the ability of a person to move. Locking a seatbelt on a patient's wheelchair, putting up arm rails on her bed, or tucking in sheets so tight that a patient cannot move are considered restraints. It is imperative to identify appropriate versus inappropriate uses of seclusion and restraint. The use of seclusion and restraint should only be utilized as a last resort to prevent injury or self-harm. It is a technique that is implemented in a crisis response to ensure safety of the patient or staff. The use of seclusion or restraint should never be used at the convenience of staff. Being short-staffed on the floor or not enough staff to watch a patient is not a psychiatric emergency. Additionally, seclusion or restraint should never be used as coercion or punishment. Working in a psychiatric setting means staff will routinely work with patients who are disoriented, loud, or present with disruptive behaviors. These are normal findings in patients experiencing a mental health crisis and are not a reason to place them in seclusion or restraint. Seclusion or restraint should always be used as a last resort and only after other least restrictive interventions have been attempted. Over the next couple slides, we will review the Eastern State Hospital policy on seclusion and restraint. The Eastern State Hospital policy for the use of seclusion or restraint clearly states that utilization of such interventions should be based on the patient assessment in that moment. It must be clinically justified, used only in an emergency situation as a last resort to control severely aggressive or destructive behavior that places the patients or others in imminent danger, should only be used to ensure immediate safety of the patient, staff, or others, and must be discontinued at the early possible time and never be based on previous seclusion or restraint history or a history of past dangerous behaviors. The use of seclusion and restraint must be justified in that moment based on the current assessment of the individual, and the type of technique of seclusion or restraint used must be the least restrictive that will be effective. The ESH seclusion and restraint policy also states that all staff will receive training that provides awareness of how the use of seclusion and restraint may be experienced by the patient. If the patient has a guardian, they must be notified if a patient is placed in seclusion or restraint. If the patient does not have a guardian, but they wish for their family to know, ESH employees may notify families as long as patient confidentiality is followed. If staff think the use of seclusion or restraint might be used on a patient, policy states the patient has a right to know and that we should discuss it with them. The use of restraint should only be applied by staff members who have been trained in how to properly apply restraints. If a patient requires the use of seclusion or restraint, the order and all documentation must be completed thoroughly. A seclusion or restraint order must specify least restrictive interventions that were attempted prior. An order for seclusion or restraint can never be written as a PRN order. Staff cannot discontinue an order, then restart a seclusion or restraint under that same order. A new order would need to be obtained. At times, a patient in seclusion or restraint may have to use the restroom, receive food, or require range of motion exercises. These types of releases are not considered a discontinuation. The use of seclusion or restraint must be written by a physician or APP. It is worth noting, in an emergency situation, a RN may initiate the use of seclusion or restraint without a physician or APP order to ensure safety. If this occurs, the RN is responsible for notifying the provider and obtaining the order within 15 minutes. Orders written for seclusion and restraint must state the reason, the type of restraint, the body part being restrained. All orders expire after 2 hours and a new order must be obtained if seclusion or restraint use is required beyond that. If the use of restraints is needed in an emergency situation, the restraint strap should be snug but not tight enough to interfere with circulation. Body extremities should be released every 2 hours and range of motion exercises performed. Restraint should never be covered up and always in full view. The head of the bed should be elevated 30 degrees, utilizing a wedge for any restraint placed over the abdomen. When utilizing this type of restraint, the vest goes over the patient's clothes, above the breast, and under the arms. A slip knot should be used to tie the chest restraint that allows for easy release. If the chest restraint is too loose, it can cause strangulation, and one that is too tight can cause asphyxiation. A person placed in seclusion or restraint must be monitored at all times on a one-to-one observation. Staff assigned to the one-to-one observation should utilize the seclusion restraint flow sheet and document the patient's condition every 15 minutes on the form. This assessment includes physical and emotional well-being of the patient, ensuring the patient's rights, dignity, and safety are maintained, assessing respiratory status, circulatory status, mental and cognitive status, and any signs of distress or agitation. Additionally, you should monitor for skin breakdown, determine if a less restrictive intervention can be implemented, monitor for nutrition, toileting, and hygiene needs, and any injuries caused by the restraint. And of course, readiness for discontinuation of seclusion or restraint should always be monitored. When the patient has calmed or when a less restrictive intervention can be implemented and the use of seclusion or restraint discontinued, it can only be done by a qualified, trained staff. Discontinuation should always happen as early as possible, and it is important to let the patient know why the intervention was used and what criteria will prompt the discontinuation. Afterwards, the event should be processed with the patient. This allows for a better understanding of why the intervention was used. It allows the patient an opportunity to process the event and provides an opportunity to identify soothers that could be implemented in the future. If at any point during the processing of the event angers the individual, it should be stopped and discussed later. Thorough and complete documentation of the incident must take place. The order should be signed by the provider. A note should be written on the shift assessment that includes the intervention attempted prior to use of seclusion or restraint, the rationale for use, the patient's response, any change in patient condition, criteria used for discontinuation. We should note if a debriefing occurred, if there were any injuries sustained by the patient. The seclusionary flow sheet should be completed in real time during the event. The staff assigned to the one-to-one observation should be documenting on that form. Staff are required to notify the provider and guardian or family if applicable. The shift coordinator sends out an incident email and SBAR form that summarizes the incident. It's key to understand that good alternatives to seclusion and restraint do exist. On this page, you will see a list that represents a very small number of available options to staff that can be used instead of seclusion or restraint. Identifying any behavioral changes in the patient's condition early can decrease the use of seclusion or restraint. Offering the patient a timeout, providing distraction activities, sensory modulation, or snacks are all acceptable alternatives to use outside of seclusion or restraint. The use of de-escalation techniques is vital when interacting with a patient experiencing a psychiatric emergency. Maintaining a calm demeanor and voice, utilizing the supportive stance, showing empathy, providing reassurance, and allowing the individual to vent are all great examples of proper de-escalation techniques. At times, PRN medication might be used and is an acceptable treatment intervention. Sometimes, alternatives to the use of seclusion or restraint may require thinking outside the box, but there are numerous options available to healthcare professionals to utilize. It's not uncommon to hear staff say that it is only a number when referring to the time a patient spent in seclusion or restraint. Well, that's not only incorrect, but it's also a poor understanding of what that number represents. The Centers for Medicare and Medicaid Services and the Joint Commission use seclusion and restraint rates as one of the measures by which the quality of care provided by a psychiatric hospital is measured. There are numerous adverse outcomes that have been associated with the use of seclusion or restraint. Patients placed in seclusion or restraint have shown increased agitation, restlessness, and disorientation. Patients have described a loss of dignity, have experienced trauma, or at risk of being re-traumatized and suffering from negative feelings such as hopelessness, guilt, and shame. Physical effects have included skin breakdown, deep vein thrombosis, bruises, cuts, fractures, and in some cases, death. The use of seclusion or restraint can increase a patient's length of stay, decrease their satisfaction, and increase poor outcomes. Research and ESH data shows that the utilization of seclusion and restraint increases the risk that both staff and patients experience injuries. Research has also shown that staff or patients who witness the use of such measures can also experience trauma. On this page, you will see a list of direct quotes from patients who were placed in seclusion or restraint. I would like to take a moment to review some of those with you all right now. One individual stated that they were unable to rest and felt worthless being locked in a room. One described how they did not understand why they were placed in seclusion. Many expressed fear and anger towards staff who implemented the seclusion or restraint. One particular individual caused self-harm by choking themselves, hoping that someone would open the door to let them out, only to be placed in restraints. Another person felt trapped and when not released or provided with an opportunity to use the restroom, urinated on themselves. In conclusion, it is paramount to understand that as a healthcare professional, we are tasked with taking care of people who are experiencing a wide range of mental illnesses. Most agree that the use of seclusion and restraint is seen as a treatment failure. If you feel a patient does not meet the criteria to be placed in such measures, make the suggestion. Remember, the use of seclusion or restraint presents serious risk and harm to patients, including physical and emotional trauma, injury, and even death. Therefore, it's crucial for nurses and providers to explore alternative interventions, implement new strategies, and work collaboratively with patients to promote a safe and effective care that upholds the patient's dignity, autonomy, and rights. Thank you for taking the time to review this presentation and education.